Okay, you guys ready to do some case studies? I just have to ask, how many of you actually answered some of the case studies over lunch? Oh, we have a couple nerds in here. Good job. Love it. And so how about that dashboard? Is that exciting or what? Yes. We are so excited by it, and this is just phase one. So once this kicks off later this month, give us your feedback. Let us know how we can improve it and build it out to be even bigger. We're super excited on the long-term care team because usually we're the stepchildren to NHSN when it comes to the patient safety side. So how many of you use the patient safety component in here for acute care? So we're kind of like the followers behind that larger component. But guess what? They don't have the dashboard. So now that, they have a different type of dashboard, but now that we've developed this dashboard for long-term care facilities, we're really excited because other components of NHSN are wanting to copy our dashboard, which we're happy to share it. But it just feels good because just like long-term care facilities are still behind the innovation behind hospitals, it's the same way with our component too. So it just feels good to be moving in a good direction. And I do have to say that I really see long-term care facilities also moving in the right direction, because where a lot of these facilities are today, with no computers or printers or, lack of resources. Hospitals used to be like that. In fact, when I first started in nursing, I remember infection control wore just as many hats as you wear now in the hospital as you guys wear in the nursing homes and the long-term care facilities. So we did employee health, risk management, quality management, and everything else that you all have to do. And I heard a new one yesterday. Someone in here told me that she is also the HR person for the facility. That was the first time I've heard that. Or anyone else in here do HR in addition to? So I really think there's hope, and you will be the leaders leading the way for residents in long-term care facilities. So it really is an exciting time to be in the field. So if you did not get a paper copy of the case studies, they're at this table up here if you would like a copy. Hopefully they don't include the answers, just the case studies. All of this session will be polling questions. If you want to log in on your phones or your computer, if you have not already done so. Okay. So we're going to help Jane today. So meet Jane. Jane was recently hired as an IP to work for DHQP Nursing Home. Prior to hiring Jane, the recently resigned director of nursing had responsibilities for infection prevention and control, including participating in NHSN. Jane is a new IP, but she is hopeful that her pediatric experience will help her in her new role. This facility has 125 beds and includes a 25-bed skilled nursing unit, a 25-bed locked unit for dementia care, and a 75 general nursing care beds. Jane is very excited to start her new job as a new IP for this NHSN facility. How many of your offices look like this? So she is excited, even if... Wait, raise your hands. Whose office looks like this? All right. That's what I like. But I guarantee you know where everything is, don't you? Mm-hmm. I was looking in here to see if I could find a plant anywhere, because I'm sure there's a plant in here somewhere. Okay. So it's her first day on the job, and the new DON informed Jane that she will need to use NHSN for surveillance and data reporting. Since Jane has never used NHSN, what is the first step she must take? A, ask the DON or another NHSN user in the facility to add her as a new NHSN user so she can register with SAMS and receive her personalized SAMS grid card. B, re-enroll the facility and enter herself as the NHSN facility administrator. Or C, add herself as an NHSN user. You guys, I don't even think we need to do this session. They already know all the answers. Very good. So the correct, and I see my data people over here saying, hallelujah, they did not pick B. Very good. So she will need to ask that DON or another user in the facility, just simply go into NHSN and add her as a user. And once they add her as a user, she's going to get that same email that you all received with instructions to go through the SAMS process. But I think we have some bad news because the DON informs Jane that she also does not have access to NHSN. How many of you have been in that situation? Yes. The previous DON was the NHSN facility administrator and the only one with NHSN access. So now what? So A, if possible, contact that previous DON and ask her to log back into NHSN and add Jane as a user and reassign the role of NHSN facility administrator to her. B, re-enroll the facility and enter herself as the NHSN facility administrator. C, add herself as an NHSN user. Or D, if it is not feasible to request the previous DON to reassign the NHSN facility administrator role, request the new DON to submit a letter to NHSN requesting the NHSN facility administrator role to be reassigned to Jane. So there's more than one answer on, or possibly on this one. This one has you thinking. Okay, you guys did good with this. So the correct answer, is it showing you the correct answer? Okay, so the correct answer is A and D. Let me go to this next slide here. So if it's possible, if your NHSN facility administrator resigns and it's possible to contact that person and ask them to log back in, because just because they resign doesn't mean they lose their SAMS grid card, because your grid card goes with you wherever you go. So if you go to a new facility, take your grid card. That's your grid card. You only have to go through SAMS one time. So it's not based on the facility you work. It's based on you as a person. So if it's possible to have the previous FAC admin log in, reassign the role, that would be the easiest thing to do. If that is not possible, then you do have to contact NHSN. And right now, the process is you have to submit on your facility letterhead just a simple request requesting that the NHSN facility administrator role be reassigned to the new person, and then put the new person's name and address, and then sign it and fax it over. We are working on an electronic form that will be available hopefully soon, that we're going to keep on our website, where you just take the form, you check a box, you put in the new person's information and fax it over. So it's going to make it easier. And then the next step is we're going to make it electronic for you guys, so you can do it online. So right now it is a little bit tedious, but that's what you have to do. And it has to have a physical signature. So we've had the facilities email the letterhead to us and just have the email signature at the bottom, and that doesn't work. It has to be physically signed by someone in leadership. It doesn't have to be the executive person, but a DON or a medical director or someone in a leadership role. And it cannot be the person who the role is being reassigned to. Does that make sense? And does someone have did you have a question? Yes, absolutely. you're right on. You are ahead of me. That's exactly where I was about to go. You're right. You're right. So, and we're going to talk about that. And that is very, very important. So I'm glad you brought that up. So basically, when someone leaves your facility and that person is an NHSN user, they have continuous access to your facility data until they are deactivated, which is another reason why it's really important to get that role reassigned or have two users so the second user who's still there can deactivate that person. And we're going to talk about that. So that is a great point. And just a reminder, a facility should only enroll into NHSN one time, because what happens, and we've had an influx of this recently, when the NHSN facility administrator leaves a facility, I guess for some people, either it's easier for them or they're just confused, but they will re-enroll the facility and change the name a little bit. So what happens is you end up having two facilities in NHSN, and we don't know which one is the correct facility, so we can't do anything with your data. So it's very confusing. And right now we have about, 200 facilities in NHSN that are enrolled at least twice. So it's a problem. And so just be sure that you only enroll the facility one time, and just reassign that role. This is just giving you some instructions on how to reassign the role of an NHSN facility administrator. So basically, you're going to log into your facility, and at the bottom here where it says facility, you're going to click, and then third down says add edit component. Once you click on that, you're going to scroll. This is like toward the bottom of the page, and you're going to see contact information. And this is going to be all of the users in your facility. From there, so you can see the facility administrator, and if you're able to get the current NHSN facility administrator to log in, he or she can easily just reassign that role to a new person. It's very easy. The other person that needs to be reassigned is the facility primary contact, because think about when you enroll, usually you have the option to assign a primary contact for NHSN. Most of the time, that's the same person as the NHSN facility administrator, right? So if that person is no longer with the facility, you'll also want to reassign this role. So it's always a good idea, if you're new to a facility that's already an NHSN facility, once you get access, I do recommend that you go in and take a look at the users in the facility. And if there are any users listed that are no longer with the facility, go ahead and deactivate them. And you can do that by clicking edit and then just follow some instructions. I bet there is. That would be on the SAMS side, and that is actually a great question. Do any of my team members know the answer to that? I am sure that there is. We would have to find out from the SAMS team, because that's really their area of expertise. But my guess is yes, if the same email address follows that person, because everything goes by the email address.
Oh, sorry. So they'll create a user ID that's associated with the address, the email address that you previously gave. But the not token.
The grid card.
Grid card, right? And so the grid card will be associated with that user ID. Now, the problem what we would run into is whether or not SAMS will allow us to submit a request to change that user ID and associated grid card to a new email. Previously, we've tried it. Hasn't worked. They usually require a new user ID, but we could certainly make the inquiry.
Would you need a new grid card? Like, I went from being a facility administrator to a quality improvement specialist at a QIM. Would I need a new grid card or not necessarily? Can that get worked out?
and your grid card was associated with,
With the email from the previous position.
right, so that's where we'd have to make the request, whether or not we can, SAMS can accommodate switching your user ID and grid card to a new email.
And they can do that.
Or does that have to come through NHSN?
You have to contact SAMS to do that. But at the same time, well, I'm assuming that they've deactivated you as a user for that facility.
Not assume that.
Hopefully they have deactivated you, but what I would recommend is call SAMS, because they do that. They will change your email address, but if you're still associated with a facility, you have to kind of at the same time as you call SAMS and then ask them, okay, when do I update my email as an NHSN user? So you kind of have to do those simultaneously, but definitely the first step would be to contact SAMS and let them know that you left the facility and you need to give them your new email address.
Hi, I just asked that if you have a question, please find a microphone. We want those that are participating remotely to also hear your questions as well.
Thank you, Courtney.
I just want to share something with you, and I don't know if this can help some of the people here, but something that we have seen is that people working on these facilities enrolled in SAMS with the generic email, and that's a huge burden or problem, because if you have a generic email, say my name is Sonia Alvarez, salvarez at xfacility.com, that email is gonna, I'm gonna carry that email wherever I go. So the next person who comes to this facility, if I leave that facility and wants to use that generic email, they can use the generic email in the facility, but if they want to register with SAMS, they are not going to allow that. I don't know if I'm
You're right.
explaining.
You are
me
right.
So I just want to
basically-
share that, because that's a big problem,
Yes.
and the people get frustrated and then they don't want to register more.
That is a great point. So there are many facilities out there that assign one generic email address. And so the problem is, if that NHSN user leaves the facility, that generic email cannot be used again for SAMS because it's associated with that person. So if you're we actually have a guidance document on our website, and if you're not able to find it, email us and we'll send it to you. But what we recommend is that if your facility is not able or not willing to give you your own email address so that you can have your own SAMS contact, then you may have to use your personal email address. And that's fine, because the SAMS grid card belongs to you, not to your facility. The downside to that would be if your facility has some firewall that doesn't allow you to check your email at work. That would be the downside. But if they don't, then you can certainly use your personal email address in those situations. Okay. After receiving her SAMS grid card, what actions would you recommend Jane take? And you can check all that apply. Create a monthly reporting plan for each month in which data will be submitted. Print the event forms for the CNAs to complete when an infection is suspected. Verify that resident care locations have been set up in the NHSN application. D, deactivate users no longer working in the facility, including the outgoing DON. E, re-enroll the facility and enter herself as the NHSN facility administrator. F, review the facility annual survey to become familiar and check for accuracy. G, identify and add at least one additional user to NHSM. Oh, yep. There's one more. There you go. You guys got it. And I didn't talk a lot about the annual report, or the annual facility annual survey, but that is the survey that's completed initially during enrollment and then every year thereafter. If you're new to a facility, it would behoove you to just go in, review the survey, and that'll give you an idea of the facility characteristics. So it's good information for you to know, but and also for the next year, so you'll have an idea of how to respond to that survey. So I do always recommend that when you're new to a facility that you go into NHSN, you check out who the current users are, you take a look at your locations that are mapped to make sure they're accurate, take a look at that annual survey to make sure that it is accurate. Go ahead and figure out what you're going to do as far as your monthly reporting plan. There's no need to print the forms for the CNAs, and again, no re-enrolling. Jane is interested in performing UTI surveillance just for the general nursing unit. Which locations must she select when submitting the NHSN monthly reporting plan? So A, she can select the general nursing unit if she has mapped the location. B, she must select facility-wide inpatient and perform UTI surveillance and reporting for all resident care locations. C, she must select facility-wide inpatient but can perform surveillance on the general nursing unit. Yeah, I knew you guys were going to get 100 on this one. So that is correct. So again, facility-wide inpatient, all units, but again, she can perform data analysis and look at specific units if she would like. And you already know this. And here we go. So here's her monthly reporting plan. If she is following UTI surveillance only, so we would check here, UTI, and then leave the others blank if you're only following UTI, and then just be sure to save. Jane understands the importance of data accuracy, just like all of you understand that, right? How can she be sure the NHSN data are accurate? A, resolve all outstanding alerts every month. B, generate data sets before running analysis reports. C, assure annual facility survey is accurate. D, submit summary data for each month, even if no events were reported. Or E, all of above. Very good. I did not spend time talking about generating data sets, but I do want to mention, if you went to, how many of you did the data analysis sessions yesterday? So you learned the importance of generating data sets. When you're going to look at your data in NHSN or run any type of report, it's really important. There's a button in the application that says generate data sets. And this will be the same for when the dashboard is available. You always want to push generate data sets before you run your reports, because what that does is it updates all of the reports with the most recent information that's been entered. Think of it as like it freezes that data for right then and there. And so that assures that you're getting the most accurate information on your reports. We talked about this a lot, so just you can use this as your cheat sheet when you're thinking about data quality. Just making sure the monthly reporting plans are complete and that your events are complete, particularly those UTI events, because remember, you're allowed to save those as incomplete events. Make sure your summary data is complete. Did you complete all required fields? Did you remember to check report no events if you didn't have any events to report for the month? That annual survey. Some things to check on your annual survey are the number of beds accurate based on the previous calendar year? Has the facility affiliation changed? Another really important question on that survey is CDI test type. That's really important because that impacts risk adjustment for your C. difficile infection rates. Have you resolved your alerts? Generating those data sets. So this is a nice little cheat sheet for you. Okay, so this one's kind of long. While reviewing positive cultures for July, Jane found that Miss Lee had a urine culture with 100,000 colony-forming units of E. coli. During the chart review, she found that Miss Lee was transferred to her skilled nursing on 7/4 after having hip surgery. On 7/5, Miss Lee complained of burning when she goes to the bathroom and feels like she's constantly needs to urinate. The urine culture was ordered on 7/5, but was not collected until 7/7. After reviewing the NHSN UTI criteria, Jane knows Miss Lee does meet NHSN SUTI criteria, but not sure if the event should be reported since Jane recently transferred to the facility. What advice can we give Jane? A, don't report the UTI to NHSN because it was present on admission to the facility. B, report the UTI since the urine culture was not collected until 4 days after admission. Or C, since Jane is new, she gets a 1-month learning curve and doesn't have to report anything. Okay, so this one's kind of close. So let's take a look at this. So the correct answer is A, and let's take a look at here. So Jane was admitted on 7/4, right? And then on 7/5, so the very next day, she complained of burning when she goes to the bathroom. So that would be some dysuria possibly, and she feels like she constantly needs to urinate. So some frequency, incontinence maybe. So in this case, her onset was within that 2-day time period. So this would be considered present on admission, even though that urine culture was collected several days later. The actual onset of this event started within 2 days of transfer to her facility. Jane doesn't understand how to apply the new onset confusion and functional decline criteria for CA-SUTI. Which of the residents below fits NHSN CA-SUTI criteria? A resident who is usually able to follow instructions has been unable to focus or pay attention to instructions for the last couple of days and has a white blood cell count of more than 5,000 leukocytes. A resident suddenly has fluctuating course, difficulty paying attention, and is not making sense during conversation and has a white blood cell count of greater than 14,000 leukocytes. Or a resident who recently begins to urinate in the bed. Excellent. So the correct answer is B. A is not correct because of the 5,000 leukocytes, so that doesn't quite meet. And then C, incontinence alone does not meet. Which of the following criteria would confirm a CA-SUTI? Select all that apply. So A, the resident's oral temperature is 100.2 degrees Fahrenheit, and the indwelling catheter specimen is positive for E. coli greater than 100,000. B, the resident has purulent discharge around the suprapubic catheter, and the catheter specimen is positive for E. coli greater than 100,000. The resident has multiple oral temps of 99.2 degrees Fahrenheit, chills, sweating, and the indwelling catheter specimen is positive for E. coli greater than 100,000. D, the resident's oral temperature is 100.9 degrees Fahrenheit, and the indwelling catheter specimen is positive for E. coli greater than 100,000. E, the resident has fluctuating change in mental status and a voided specimen positive for E. coli 100 colony-forming units 4 days after the indwelling catheter was removed. F, the resident has oral temperatures of 101 degrees Fahrenheit, sweating, chills, and the indwelling catheter specimen is positive for Candida albicans. Okay, so you guys are close. So the correct answer is A and C. Let's take a look here. So A, the oral temperature is 100.2 degrees Fahrenheit, and the indwelling catheter specimen is positive for E. coli, so that meets. And then C, the resident has multiple oral temperatures of 99.2, so that meets with the chill, sweating, and then the catheter specimen positive for E. coli. B does not meet because it's a suprapubic catheter, and remember we're looking for CA-SUTI in this one. I think we already talked about Mr. G in the last. Didn't we already talk about Mr. G? We're going to skip this one because I have a lot of scenarios and I don't want to spend time on one that we've already done, but I'll give you the answer. So the answer for this is B. So if you want to mark it on your papers. So we're going to go right over to scenario 9. Jane was reviewing her events for the month of June when she realized Mr. Jones was transferred to her SNF on 6/30 with a recent history of CDI, so C. difficile infection. She did not find evidence of a stool culture collected after he was admitted to her facility. Should she report a CDI lab ID event just to be on the safe side? Yes or no? I'm really impressed with this group. You guys have to come back every year because you make me feel like I'm a really good teacher. Thank you. But it's you guys. You guys know this stuff. This is very impressive. So you are 100% correct. If you did not collect that specimen, unless it came from the resident came from the emergency department, you do not report someone else's baggage. Okay. After getting the hang of UTI surveillance, Jane decides that she wants to retrospectively add C. difficile lab ID event to her reporting plan for June. Can she update her NHSN monthly reporting plan? A, yes, she can edit the NHSN monthly reporting plan and add CDI lab ID event to the plan. B, no, it's too late. She will need to wait until June 2015. Oh, to add CDI. Oh, talk about going back in time. Or C, she should call NHSN and let them decide. Very good. Yes, you can always edit your monthly reporting plan because the data can be entered retrospectively. Essentially, that's what you're doing anyways, right? You're not entering these every day. I mean, a lot of our facilities at the end of the month, they'll spend a couple hours, go through their culture reports and enter data. So yes, you can edit that monthly reporting plan and add additional options. You can also remove options, but remember, only if you have not already entered data in the application for that particular option. So you could add, or you could, if you decide, I want to do C. difficile lab ID event and not UTIs, you can remove UTI from the reporting plan, but only if you have not entered any UTI events or summary data. And this is a screenshot for you guys to have of how you would edit that monthly reporting plan. It's really easy. So you would find the plan and then scroll all the way to the bottom, click edit, make whatever changes that you want to make, and then just be sure to save those changes. This is an easy one. Define event date for a lab ID event. Date specimen was collected. B, the date when the first clinical evidence of infection appeared, or the date the specimen used to meet the infection criteria was collected, whichever comes first. C, the date the culture was ordered, or D, date the events were entered. So this is a lab ID event. It's a lab ID event. Did I mention it's a lab ID event? I can't take it anymore. I'm going to have to show you the answer. The correct answer is A. It's a lab ID event. Remember, for your lab ID, and that was yesterday. I know I've given you a lot of information, so I'm going to cut you some slack today. The date of event for a lab ID event, remember, is the day that specimen is collected, because for the lab ID events, you're not looking at any clinical evidence, really. You're just looking at the positive specimen and the admission date, right? Okay, we might have to come back around on this one. Try that again. Okay, scenario 12. How are you guys doing? Are you good? Okay. Mr. Smith, a resident in your facility, developed copious diarrhea and was sent to the emergency department on 6/1 for evaluation. While in the emergency room, a loose stool specimen was collected and tested positive for C. difficile. Mr. Smith received IV fluids and a new prescription for Flagyl, returning back to your facility on 6/2. According to NHSN Lab ID event rules, should Jane submit a CDI Lab ID event for Mr. Smith? Yes, A. B, no. C, I wasn't paying attention during the Lab ID event presentation. I knew it. That has to be the web streamers because all of you are alert. Very good. So yes, she will submit that lab ID event because Mr. Smith did return to her facility within within 2 calendar days of that outpatient visit. Good job. Okay, we've got one more related to Mr. Smith. Should Jane include Mr. Smith and the monthly summary count for the number of admissions on C. diff? So he went to the emergency department, tested positive, received a new prescription. This one is kind of tricky. So should Jane include Mr. Smith and the monthly summary count for the number of admissions on C. diff treatment? So is an outpatient visit and return an admission? Correct. You guys got it. So since he just went to for an outpatient visit and not actually left the facility. Now, if he had been there for more than 2 calendar days and then was admitted after 2 calendar days on Flagyl, then you would. But an outpatient visit is just considered a visit, not an admission. Good job. Oh, I have another one related to Mr. Smith. Should Jane include Mr. Smith in the monthly summary count for residents started on antibiotic treatment for C. difficile? So we had this question before lunch. So A, yes, B, no, or C, I still wasn't paying attention during the Lab ID event presentation. Very good. The correct answer is yes. Yes, since he was still under the care of the long-term care facility, so there was no change in the current admission date. And chances are, we talked about this over lunch, chances are your resident goes to the emergency department, they're going to write an order for whatever antibiotic, and then the resident's going to come back to your facility, but that order is going to probably go in your pharmacy system, right? So it will look like a new order from your system. Is that true? So we did have some healthy debate whether this should be included or not, but we concluded that it should be included because A, it's an outpatient visit, and we're telling you to include the outpatient visits and everything else, that it's related to the facility, and B, it may be kind of confusing if you're just looking at pharmacy orders and you see the new pharmacy order, but maybe you don't know it was related to the ER. So we say yes, go ahead and include that in that count. Is that okay? Does that make sense to everyone? Okay. Scenario 13. While continuing to review positive lab results for July, Jane found that Ms. Brown had a positive C. difficile PCR on July 15th. During chart review, she read that Ms. Brown was admitted to the long-term care facility on July 14th, and a loose stool specimen was collected on July 15th. Additionally, Ms. Brown was started on oral flagyl on July 15th. Jane is unsure if she needs to report this positive C. diff and needs our help. What advice can we give her? A, don't report a CDI lab ID event to NHSN because it was community acquired. B, report a CDI lab ID event to NHSN since the specimen represented the first positive C. diff from this resident. C, again, Jane is new. She gets a 1-month learning curve and doesn't have to report anything to NHSN. Okay. So the correct answer is B. So remember, you are going to report all of your positive specimens that don't represent a duplicate. And remember, the duplicates are based on specimens collected in your facility or the outpatient visit. So even if the specimen is collected on the day of admission to your facility or the next day, you know that that's not associated with your facility. But because we're looking at admission prevalence of C. difficile and these MDROs, it's important to capture those. So go ahead and enter that. But remember, NHSN will categorize that as a community onset. So let me ask you this. What if it's collected on a weekend or holiday or overnight? Would you report that? Yes. I just trying to be serious and give you a trick question. Okay. How will NHSN categorize that CDI lab ID event submitted by Jane? So reminder, her current admission date is July 14th, and that specimen collection date is July 15th. Will it be categorized as community onset, long-term care facility onset, or acute care transfer, long-term care facility onset, ACLO? So remember, when you're thinking about categorizations, you kind of want to think, first, is it community onset versus long-term care facility onset, right? And then only those long-term care facility onsets are further categorized. There you go. Very good. So the correct answer is A. So since this was collected on the day number 2 of her current admission, it would be categorized as community onset. Now, had this been collected day 4 or after, you are correct if you answered C, then it would have been categorized as long-term care facility onset, acute care transfer, so ACLO. But because it was community onset, there's no further categorization as far as transfer goes. Okay, and this is just a reminder for you to have of the categorizations and how they are defined. Based on the advice we gave Jane about the CDI lab ID event, would we advise Jane to include Ms. Brown in the July's monthly summary count for number of admissions on C. diff treatment? Yes or no? So number of admissions on C. diff treatment. Very good. So the correct answer is B, no. So we have no documentation to indicate that Ms. Brown was receiving treatment at the time of admission, right? So we would not include her in that particular variable. However, would we include her in the number of residents started on antibiotic treatment for C. diff? Yes or no? Good job. Correct answer is yes, because we do have documentation that she was started on Flagyl for C. diff in our facility on July 15th. Excellent. Uh-oh. Scenario 14, this is your worst nightmare. When logging into NHSN on a Friday at 4 o'clock, Jane notices the following alerts on her screen. Since she is new and these are not her mistakes, does she still have to do anything with these alerts? A, yes, all alerts must be resolved before data are considered complete. No, she can clear these alerts and start fresh since she is new. Or C, she must ask her DON. You guys are correct. A. Unfortunately, although it's not her mistake, she's the new IP, so yes, she does have to get these resolved. And this would be a good time for her to go ahead and add some additional users and maybe get some help. Maybe a good time for her to train her new DON. So I know you guys already know about these alerts. I'm not going to read this to you, but just know they have to be cleared so that your dashboards look good. Scenario 15, Jane is attempting to resolve an incomplete event alert. After clicking on the event number, here is the incomplete event. What is wrong with this picture? A, the specific event criteria is not met. B, the specific event needs to be typed in. Or C, NHSN has a defect. I'm going to keep this screen up for just a minute just so you can see, because the next screen won't have the picture. So let's see where you guys are here. Excellent. 100% of you are correct. So the correct answer is the specific event criteria are not met. So we have the lavatory here, but if you look up here, it says indwelling catheter is not in place. So we're trying to meet a what? SUTI, because there's no catheter in place. So SUTI, you have to have a little bit more. So right now we just don't have what we need to meet SUTI. So the specific event is not populating. And so that's our clue that something is wrong. So we either need to go back to the chart to figure out if the resident has additional signs or symptoms. And if not, just go ahead and delete this from our data set. So you can see here, if I added just one additional check mark, we would meet the SUTI. And this is when, where it really is a good idea. So these figures I was telling you about that have the SUTI criteria on one page and the CA-SUTI on the other, it's really a good idea just to keep these handy. And honestly, I've been doing this for a long time. I have these printed next to my desk because I need them, and maybe that's age related, but I have to have that reminder. So don't feel like you're not smart if you have to go to that figure, because even we use the figures. Scenario 16. In reviewing historical surveillance data, Jane verified that 0 UTIs were identified during the month of January. Since the facility did not report any UTIs to NHSN, does Jane still need to submit the NHSN monthly summary data for January? Yes or no? You guys are pros. Correct answer is yes. And again, I just included a screenshot for you so that you guys could have a refresher of how to do this. And as a reminder, the monthly summary is required if you have a reporting plan in place, even if there have been no events submitted. Jane sees a new order for macrobid on a resident with a UTI. While reviewing the chart, she notices the medication was started and then changed once the sensitivity results became final. Should Jane count this antibiotic in NHSN monthly summary count for new antibiotic starts for UTI indication? Yes. Only count the macrobid since it was administered first. B, no, the full treatment was not given, so it should not be counted. C, count both the macrobid and the new antibiotic. And my mouse is acting up like a child up here. Well, this gives you a little more time to think. Oh, here we go. Okay. So the correct answer is C. You want to count both antibiotics. So remember, it does not matter the duration of the antibiotic. Any antibiotic started should be counted. And again, this is just a reminder to capture all new antibiotic orders regardless of the number of doses or days of therapy. In reviewing the NHSN UTI criteria, Jane does not understand criterion fever of greater than 99 Fahrenheit on repeated occasion. Let's give her an example. A, resident has a documented temperature of 99.2 the day before the urine culture was collected and for 2 days after the urine culture was collected. B, the documented temperatures must be consecutive. C, resident has more than one documented temperature reading greater than 99 degrees Fahrenheit. Or D, A and C are correct. Excellent. So A and C are correct. Basically, you're just looking for more than one documented temperature, and it doesn't have to be consecutive. You want it to be within a reasonable time frame, maybe 5 days. Some people may want to do 7 days, but you want it to be clinically reasonable. But as long as you have more than one, then that criterion can be used. Scenario 19, Mr. Clark is a nonverbal, incontinent resident and was noted as having twitching of the face, hands, and legs. He was sent to an ER for evaluation where a urine culture was collected. He returned to the SNF the same day with a diagnosis of UTI. And the culture came back with Klebsiella pneumonia, greater than 100,000 colony-forming units. Should this be reported as a UTI event if the patient is unable to verbalize any potential symptoms? A, yes. If the ER diagnosed a UTI, then he must have one, right? B, no. A positive urine culture alone does not meet UTI. Or C, maybe. I need more information to determine if Mr. Clark meets NHSN criteria. I like the way you think. Yes. I agree. you need more information, right? We've got to determine what else is going on with Mr. Clark here. So let's see if we can get some more information from Jane. Upon chart review, prior to being sent to the ED, Mr. Clark had a noticeable increase in twitching of the face and legs during the lower abdominal exam, and his urine was pink in color. With this new information, plus the positive urine culture collected in the ED, should Jane report a UTI event? Yes or no? So everyone agrees with yes. I agree with yes too. So this is an example of where you may have to make some clinical judgment, right? Because even though the patient or the resident can't tell you, oh, my lower stomach hurts, you're able to look at those facial grimaces, the body movements, and sometimes you just have to do that. It's when you have certain populations. So you may have a resident population that, like we talked about earlier, confused, some functional decline. You may have paralysis. And so you have to get creative with trying to figure out their pain. And a good physical assessment is always helpful, plus the documentation. So it looks like we're all in agreement there. And this is just the figure 1, and I highlighted on here what if I were reporting this, how I would report. I would put new marked increase in suprapubic tenderness, gross hematuria, and then the specimen. And probably what else I would do is just put in the comment section, just so if my DON or administrator or medical director ever validated my events and said, why did you report this? I would have a comment to remind me, because the documentation said this. So it's always good just to have those comments for historical purposes. Scenario 20. Jane is preparing to submit the facility's NHSN monthly summary data for June 2019. During the review, she was unsure of which residents to include in the summary count for number of residents started on antibiotic treatment for C. difficile. She needs our help. Should residents who receive empiric treatment be included in the summary count for number of residents started on antibiotic treatment for C. diff? This is a common question we get. Excellent. You guys are correct. Yes is the correct answer, so that empiric treatment does count. So it includes all residents with an order for treatment. So those tested, those not tested, even those tested with negative results would be included in this number of residents started on treatment. Scenario 21. Jane is interested in participating in the NHSN Prevention Process Measures module. NHSN recommends which useful data collection tips to monitor hand hygiene and gown and glove use. Oh, hold on. Let's set this up. Oh, there we go. A, observations should be discreet. B, try to ensure that observations are as representative as possible of normal practice at the facility. C, focus on an area of the unit where staff interaction with residents are clearly visible. D, perform at least 30 different unannounced observations. Or E, all of the above. Ty, you will be proud. They listened to your presentation. Very good. You guys are making Ty proud. So you guys are correct. It's all of the above. And this can get tricky sometimes if you don't follow that module. Sometimes it's hard to remember how many observations you should be doing, but NHSN does require at least 30 different unannounced observations in order to enter data. So if you were to enter anything less than 30, it would give you an alert that says you must have at least 30 observations. So I wanted to put that on here so that you don't waste your time and go on July 20th, go do your observations and get 29 observations and try to enter that, and it. Okay. True or false? The data reported into the annual survey are reflective of the year the survey is completed. Very good. Correct answer is B, false. The data in the survey, aside from one question that specifically says on the day you complete the survey, other than that one question, everything in the survey is based on the facility characteristics and practices in the previous calendar year. Yeah, sure. Sure.
When we were talking about doing the observation on the previous question, this past week there was, I don't know how many are APIC members, but on their blog, the My APIC, there was a whole bunch of dialogue from IPs across the country that were talking about that very issue of how do you best, observe and do it discreetly. And there were a lot of people saying, "Oh, we should have secret shoppers," and they're actually hiring some patients to do this, and they're taking surveys, and they're bringing in people that don't even work in the facility, and there's all this stuff going on.
They're getting creative.
So I was reading through all of that, and so when you were talking before about this, is that? I mean, I know you guys aren't, CMS, but at the same time, do you have any thoughts on that?
I'm going to
Because it's a little hard sometimes, because the initial comment that was made by the IP was that it's like she'll do 10 a month and every single one of them are perfect 100% because they kind of know what's going on. So
of course. I would say that when I was in the hospital, I used to do similar to what you're talking about. If we had nursing students on the floor, those are the best because everybody thinks the nursing students are clueless, right? So I would get the nursing students to be my observers. The dietary, I would have them. I would pick the most non-assuming individuals, or I don't know if that's the right word, but individuals that you wouldn't think are watching you, the most non-threatening, maybe that's the word, individuals to do those observations. So I think that's a great idea. And I'm going to, Dr. Rowe actually works in long-term care. Do you have any thoughts on
I don't
these
know
observations?
of any like CMS rule, regulations or anything that would say that you can't do that. It might be a facility specific thing. You might have each facility might have to check with their individual policies. But I don't know off the top of my head whether there's any. It seems like a very novel strategy. But yeah. Sure. Yeah, no, I think that's. Oh, did somebody else have any? I was wondering too if anybody else in the room had any.
I think if you are showing that you are being consistent in how you're educating your observers, as long as you're showing that they're educated to follow the exact same methodology, I think that's great.
Yeah, I was going to say, working as a nurse surveyor for the state of Georgia, it is not a CMS requirement that how you educate, consult your staff to be in compliance with hand hygiene, long as you're able to show education and there's not an issue. They wouldn't bother to look at it unless it becomes a concern to link how are you educating or monitoring those things, but it's not a single requirement under F881.
Oh, thank you for letting us know from your standpoint. That's great. And I would even say, be creative and make it a game. So when you make something punitive, when you say you have to get that flu shot or you're getting fired, or you have to wash your hands or you're getting written up, right? You don't want to go with that approach. You want to make it fun. You want to make it a competition. Most of us like a healthy competition, right? So we're going to we're going to have these secret observers. We're going to be monitoring staph influenza, and the unit or the pod with the most adherence or the highest score, you get a pizza party, or you get, I would say PTO, but I don't know any administrators in here. You might throw something at me. You may get a day off, or just so I would say whatever you're going to do, make it fun and do it in a way that the staff want to participate, not have to participate. That's a good question.
I was just going to add, I agree. I think the sort of positive reinforcement is really useful. And I think a lot of people tend to really, I think are very motivated by positive reinforcement. And that is something that we do. So we'll like display some of our results up and, look at for a month for hand hygiene. And we use candy bars, which chocolate's always great. So
yeah, chocolate is the best. The new DON requested to see an NHSN UTI rate report for June. Hopefully, Jane has already fixed those alerts. Before running this report at NHSN, Jane knows that she must first select all that apply. A, verify that all UTI events in June were submitted to NHSN. B, verify the complete monthly summary data were submitted for June. C, verify that all outstanding alerts for June have been resolved. D, generate the data immediately before running that report. Or E, all of the above. I knew you guys would get this one. Very good. So all of the above, all of those are important to do right before running that report. And that way, Jane can go to her meeting with confidence that she is presenting the most accurate data to her DOM. Okay. Now that Jane has more experience with NHSN, the DON has asked her to help enroll a sister facility into NHSN. What are the first steps for enrolling a new facility into NHSN? A, identify who will be the NHSN facility administrator for the new facility. B, access the long-term care facility enrollment page and follow that 5-step enrollment process. C, the identified NHSN facility administrator will register the facility with NHSN by reading and agreeing to the NHSN facility or group and a group administrator rules of behavior. And D, all of the above. Very good. So the correct answer is D. Would highly recommend that Jane go ahead and access that 5-step to enrollment, possibly print off an enrollment guide for each of the users in the facilities and just use that to help enroll. And here is our page that the 5 steps to enrollment and the web address for you. It's been 12 months since Jane started her new position as an IP at DHQP Long-Term Care Facility. She is feeling more confident in her position and thanks all of you for helping her in her journey through learning NHSM. So give yourselves a round of applause for helping Jane. And then the last page I put on there so you guys would have the link to the free IP training course that Namali, Dr. Stone's team, put together in conjunction with CMS. It's free and it is wonderful. And you can get CEUs for that. So highly recommend the course. Wow. I'm letting you guys out early again today.